Thank you for that kind introduction, Dr. Vishwanath, and good morning to everyone. Thank you for the organizers for giving me this opportunity on this International Epilepsy Day celebration. So every second Monday of the February is declared as International Epilepsy Day, basically to improve the awareness. And every year they take up one slogan to improve the awareness and remove the stigma and improve the quality of life of patients with epilepsy. As you know, this is one of the commonest neurological problem with 1 in 100 patients, 1 in 100 persons, the prevalence is very high, and we see a lot of patients with epilepsy. And almost in our neurology OPD, 30% of patients are somehow related with epilepsy, either primary or secondary. So there is a lot of need for people with skills and expertise in management of the epilepsy. Even though it is a common condition, unfortunately the treatment gap is very high, and our country needs a lot of manpower, and still a lot of stigma is there that needs to be addressed. And higher tertiary centers can cater only few patients with refractory epilepsy, but however most of the patients needs to be taken care by general physicians as well as MBBS doctors. Actually, if you have some basic knowledge, it is at peripheral level it is easy to manage, and most of them, almost 50%, are easily controlled with one drug. So all these patients can be managed at primary and secondary care centers, such that refractory patients can be taken care at the tertiary care centers with all the equipment. So already Professor Mohan sir has given in detail overview about the epilepsy as well as the management of epilepsy. Actually, he covered even the refractory part also, all the medications and all he has covered. So I will briefly revise this for the benefit of the students. So what is drug resistant epilepsy? It is a defined as failure of adequate trial of two drugs tolerated and appropriately chosen and appropriately used anti-seizure medications regimens, either as monotherapy or in combination, and achieve freedom from the seizures. So when do you say freedom from seizures?
Shall I put it in slide share mode?
Yeah. I'll do it. So seizure freedom is defined as freedom from all types of seizures for 12 months or 3 times the pre-intervention inter-seizure interval, whichever is longer, that we consider as seizure freedom time. So if two drugs, if we are able to manage adequately, then it is a controlled epilepsy. If not, then it is refractory. So if you see probability of seizure freedom after 2 anti-seizure medication failures reduces exponentially, as already sir has shown. It is only 5% that can be helped once it is really refractory to 2 drugs. So then what is the next option? If it is not controlled with medication, so is it only surgery or anything else is there? That is what we should understand. So if you see, the prevalence of drug resistant epilepsy is 30%, and there are 10 million people with epilepsy and 3 million with drug resistant epilepsy in India. So this is the effect of refractoriness of epilepsy on patients' quality of life. So it can lead to multiple medications, will lead to adverse effects of the anti-seizure medications. They continues to have seizures even on multiple medicines, and that can lead to cognitive problems and educational, occasional social consequences, mood and personality changes, and restricted quality of life. And then you can have increased mortality, greater risk of SUDEP and comorbidities, and these are all the different aspects that are going to affect the patient, and quality of life will become very bad. So, what are the risk factors that are identified for the refractoriness? So, the patients, there are some factors which are found to be highly associated: early age of onset, and symptomatic epilepsy, and abnormal EEG, febrile seizures at the during the childhood, abnormal neurological examination, intellectual disability, neurological deficits, and history of status epilepticus, and associated psychiatric comorbidities. These are the some of the factors that are associated with this refractory epilepsy. So, what causes the refractoriness? So, multiple exact cause is not very clear, but there are multiple hypotheses that are thought to be responsible for this drug resistant epilepsy, and it can start from pharmacokinetics of the each individual, and genetic variations of each person, and there can be change in the target hypothesis. The drugs which were initially working, these targets can be they may change over time, and they may not respond to the drugs. And after target, it can be the transporter, that is the secondary pathway, that can be altered with the time. So, they may develop initially, they may be responsive for few months, and then they may not they may become refractory after few months. So, these kind of secondary changes, and these are all at cellular level, and then it can cause at network level, it can cause some alterations, either intrinsic network, or then neural between different areas of the brain, network alterations can happen. So, all these factors can lead to drug resistant epilepsy. So, how do we manage? So, if you basically once it is refractory means we may think there is no role for medical management, but surgery is one of the most important thing, but unfortunately surgery is, again, if suppose 100 people are drug resistant, only 50% of them can undergo pre-surgical evaluation, as well as some of them only will be eligible for epilepsy surgery. So, still most of the patients, still we again need to manage on anti-seizure medications itself. So, still the main part of the drug resistant epilepsy lands again on medication only, and there are some additional things that needs to be addressed in this group of patients, like lifestyle changes, ketogenic diet, and neurostimulation, and other palliative things that needs to be considered. So, what are the principles in the management of this drug resistant epilepsy? So, as you know, before deciding it as a truly drug resistant, we should always rule out pseudo resistance. So, that is like it can be because of incorrect diagnosis, incorrect syndromic diagnosis, or inadequate dosing of the drug, poor compliance, and lifestyle factors such as drug abuse, sensory stimuli such as hot water baths, or other reflex epilepsy related things that needs to be considered. So, we need to identify the correct diagnosis, that is the most important thing. So, never feel ashamed that we have made diagnosis wrong in the first visit. So, that happens because when you see the patient first time, whatever history might be told by somebody who has not witnessed properly, or they may not be able to recollect properly, and what a patient will be normal, this is a paroxysmal issue. So, when you are seeing the patient, he is normal, sometimes MRI EEG can be normal. So, we may overdiagnose, sometimes may underdiagnose sometimes, but when it is not controlled, always we should go back to our initial diagnosis, whether we have made it correct diagnosis or not, whether it is seizure or not. So, that is the most important question. We always go and check, even though don't stick to the diagnosis what you made on the first visit. Yes, I made epilepsy, I won't change it. It may not be possible. Even in the best of the centers, still 30% can be diagnosed wrongly on day one. So, with repeated, the other advantage is here the patients will come for follow-up. So, always we have to go back to the history and retake the history and try to see the video clips if they have, and take the history again from the patient as well as from the relatives. And sometimes you can have combination of both, and sometimes you can have only non-epileptic events. So there is nothing to feel ashamed or that revising our diagnosis. It was finally the benefit of the patient that is more important. And then you can have sometimes seizure mimics, like as already explained, vasovagal syncope, we can have cardiac arrhythmias and metabolic disturbances and non-epileptic or pseudo seizures, and sometimes dissociative disorders associated with psychiatric conditions, as well as some TIAs and other movement disorders. All these things can mimic as seizures. So for the benefit of residents, some of the videos probably I can show to show what is actually seizure and what is not seizure. So sorry, is there any internet connection? Okay, then I'll skip it now. So meanwhile, I'll continue to the presentation. Later I can show the videos.
One second. This one is not correct. Capital V, Vydehi, hypermesis. This is connected. You can try.
Okay. So this is the commonest type of semiology that most of the people will get in the community, that is generalized tonic-clonic seizures. So you can see the initial component, there is staring, then there is a tonic component for few seconds, that is being followed by clonic jerking of the distal limbs. So this is the commonest thing that most of the people, even lay person, can identify as seizure. So this is the GTCS. So after that, other types of generalized seizures we call, that is, so this is a child who is hyperventilating. You can see suddenly there is behavioral arrest, and she was staring for few seconds, and there were increased blink rate, and she was not responding during that time to calls. She was not responding for few seconds. So this is the typical absent seizure. It is a generalized seizure again, once again. So this is the second type of commonly described generalized seizure that you see in our practice. After that, we can see some focal seizures, and one more myoclonic jerks also. It's a generalized seizure. We can just see the, so this is a generalized myoclonic jerk. So this is also another type of generalized seizure that everybody should be aware. And then we have some focal onset seizures. In the focal onset, most commonly we see temporal lobe seizures. So So this is a patient who is having temporal lobe epilepsy. So by looking at this video, many of us were not experienced or trained in epilepsy may not identify this as seizure itself. So here just patient was talking irrelevantly and she was using her right upper limb to point something and the left side upper limb is not moving at all and she was talking something irrelevant. So this is also a seizure. Seizure doesn't mean always only convulsive movements. So this is a focal onset impaired awareness seizure according to the new classification, and here some lateralizing localizing features people should aware, that is overall it is hypomotor and some irrelevant speech was there and the posturing of the left side of the limbs and right side upper limb automatisms. These are all things which points to the right temporal lobe, mesial temporal lobe kind of epilepsy. And she is responding to the commands immediately after the attack. So it lasted for probably 1.5 to 2 minutes and then she is alright. So that means she is understanding the commands immediately, that is there is no post-ictal aphasia. That also suggests that it is coming from the non-dominant hemisphere. That will help you for lateralization of the seizures. So there is another so here we can see patient is not responding to the commands. There are perioral chewing movements and she is moving this left upper limb but not moving the right upper limb, and she was not responding to the commands. So this is little opposite to the previous semiology. So here lateralization changes to the initially the right upper limb was not moving. So at this point of time the lateralization is for you, it is a left temporal lobe semiology. Subsequently in the later part she has automatisms involving the right upper limb. So that probably suggests the spread to the opposite side after some time. So these are the temporal lobe seizures. Then we also have some different kinds of semiologies, especially in children, and so this is a sudden fall. So she falls and daily she has falls and injuries. This is a atonic seizure involving the truncal muscles, sudden loss of posture and the multiple injuries they get. This is also a type of generalized epilepsy. And so this is another interesting kind of semiology that we see. So here the child is suddenly having a burst of laughter. So most of us may not realize it as seizure itself. So anything episodically, if it is happening, always keep a suspicion of seizure. So this is called gelastic epilepsy, unprovoked sudden laughter. So this is a classically seen in hypothalamic hamartomas. So we should be aware of this kind of semiology. And another common type of semiology that we see in, especially in Karnataka, is hot water epilepsy. So this is like whenever patient takes hot water head bath, so they have loss of consciousness and they can have different kinds of seizures. She is our Professor Sanjeev Sinha. So he was examining, he was not responding. There are some perioral chewing movements. He is not able to understand the commands. So this itself is a seizure. So it is the reflex seizure induced by the hot water head bath. So we call this is hot water epilepsy, and this is one common condition that is prevalent only in and around Bangalore, some of the areas, maybe some kind of environmental and genetic factors are prevalent. So always better to ask the question of, as sir is suggesting, Nataraju sir, that whenever you are seeing first time, you always should ask for the reflex nature, what are the triggers. Sometimes you can have because of eating, sometimes because of hot water, sometimes because of touch, sometimes because of any kind of reading epilepsy. All kinds of activities can be associated with reflex epilepsies. So, always better to ask the question, and the most important thing is all these reflex epilepsies can be treated with the modification in treatment schedules, especially hot water epilepsy. Nowadays we will not give daily medication, we just give the medicine before 1 hour before the hot water head bath. So, that can avoid the unnecessary medication daily. So, these are the different semiologies that I have shown just to make understand that what is seizure and what is not seizure, and there are some non-seizure videos, but because of lack of time I will skip right now. Okay. So, then after diagnosing it is as true epilepsy, still we are not able to control. The next question that you should ask yourself is whether the classification what you made is correct or not. Is it syndromically correct or not is the second question, because the nature of drugs that act in one kind of syndrome may not act in other kind. So, before labeling it as drug resistant, we should make sure that we classified the epilepsy as per the different kinds of features that we evaluate. Suppose if you take juvenile myoclonic epilepsy, if you do not treat with valproate or levetiracetam and use only sodium channel blockers, sometimes you may not be able to control it, but that does not make it as a drug resistant. It is because of wrong drug selection that is being uncontrolled. So, next thing is drug doses and compliance. So, you are giving the correct, you made the diagnosis correct and you have identified the correct syndrome and selected the good drug or optimum drug, but if you do not give the optimum dose, again you may fail. So, always use the optimum dose based on the tolerance of the patient. And then number 2 is compliance. Compliance is another problem. Many times they may not tell, and they may tell that we are taking regularly. So, in this kind of situations, sometimes we may need to do drug levels testing also, and we should educate the patients to be compliant, and also we should look for the factors that are responsible for non-compliance. So, mainly in our country it is about the drug selection. If you give some expensive drug for poor socio-economical status, they may not be able to afford it. So, and every time before buying the next month medication, they may miss for few days and again they come back with recurrence. And then lifestyle modifications, these are very important, and all these patients of drug resistant epilepsy, they have some specific triggers also, like during emotional stress, sleep deprivation, and sometimes can be triggered by bright light exposure or flickering lights, and sometimes alcohol related, different kinds of triggers may be there. So, we always should ask for all these lifestyle things, and whenever a particular thing if we can identify, try to address those things. Suppose if they have a sleep deprivation, that you should ask them to maintain a healthy lifestyle and maintain the healthy sleep quality. So, that may take care of the recurrence of seizures. And then use of anti-seizure medication, already in detail Dr. Mohan sir explained. So, again I will revise these things. A type of seizure and epilepsy syndrome we should identify, and the pharmacokinetics of the drug, its efficacy, tolerability and potential for drug interactions, and its effect on coexisting disorders and its cost. All these factors we should think while selecting the drugs. And how to start the medication. An adequate trial of AED consists of a systematic increase in the doses and plasma drug levels until the seizures are controlled or intolerable adverse effects appear. And so, this is how generally we once drug failure of first monotherapy happens, is it because of the poor tolerability or lack of efficacy, we should think. And if it is a poor tolerability, whether it is because of the any adverse effects or whether dose related adverse effects or idiosyncratic adverse effects, we should check. and then in that case we can go for alternative monotherapy. If suppose it is because of lack of efficacy, and you can add the next drug, that is called the rational polytherapy, that we are going to discuss. So, how do you manage? Is it suppose the first drug you have given and not controlled, so while adding the next drug, is it better to switch to the another medication completely or add an alternative monotherapy is one question that is being debated for many years. But overall the evidence says that there is no much difference in overall outcome if you either add the next drug or switch over to the other drug. So, you can individualize your treatment options depending on the multiple other factors and the financial condition of the patient. So, and appropriately how to choose the drugs based on the epilepsy type. So, adequate dosage for adequate duration to all the patients we need to consider before labeling them as drug resistant. So, first line monotherapy for most of the generalized epilepsies, mainly currently all for men, if it is a generalized epilepsy we can select valproate, that is the one with highest efficacy. Women right now, all the women should not be given valproate, that is a black box warning because of the side effects. And women, the best drugs for generalized epilepsy is lamotrigine or levetiracetam. This can be used for men also because of cost effectivity, better we can go for valproate in men. And second line, if the first line monotherapy with valproate is unsuccessful, second line monotherapy with levetiracetam or lamotrigine to be tried. And if the first and second line monotherapy fails, one of the add-on drugs can be considered. And add-on drugs after failure of first and second monotherapy, generally we use clobazam, lamotrigine, levetiracetam, perampanel, valproate, topiramate. And as second line add-on we can also use breviracetam, lacosamide, phenobarbital, but these are all not fixed kind of things. Depending on affordability, drug interactions, we need to select the medications. So, for focal seizures, primarily we can start with sodium channel blockers or levetiracetam still can be considered. As add-on we can add another drug. Suppose if you started with lamotrigine, you can select other mechanism of action for second line, like you can add levetiracetam or valproate or zonisamide, and third line we can add lacosamide. So, these different combinations and permutations we can try depending on the tolerability of the patient and side effects. No fixed guidelines that you have to start in this order only and you have to go like this. So, if first, second, third line monotherapy fails, then you can again the same drugs only we can try the different combinations. And especially in absence epilepsy, first line monotherapy the ethosuximide, and second line is valproate, and third line we can add on lamotrigine and levetiracetam. So, these are the different combinations that can be tried. And we also should know drugs which can worsen some subtypes of epilepsy syndromes or epilepsy semiology, like absence seizures can be worsened by most of the sodium channel blockers. So, we should not give child with absence epilepsy carbamazepine, oxcarbazepine, phenytoin, these drugs. And myoclonic seizures also can be worsened by some of the medications, and best controlled by valproate and levetiracetam, and you can add one if other one is not helping. And other drugs which can be tried in myoclonic seizures are breviracetam, clonazepam, and other like zonisamide, topiramate, these things. And the drugs which can worsen myoclonic seizures we should know, like carbamazepine, oxcarbazepine, lamotrigine also sometimes can worsen, phenytoin can worsen. So, tonic or atonic seizures, again valproate or lamotrigine, one of the best drug, and lamotrigine can be added if you are selecting as other drug, and these are the other drugs which can be added. So, worsens tonic seizures are worsened by sometimes to carbamazepine, oxcarbazepine, and gabapentin, pregabalin, and vigabatrin. So, these are the drugs that are used in idiopathic generalized epilepsy, mainly as we discussed lamotrigine and valproate, levetiracetam, these are the three drugs that we use in IGE syndromes, and we can add on these drugs perampanel is another add-on for the IgE syndrome, and topiramate or joensemide also can be tried. So how to combine these anti-seizure medications? So this is called with different pharmacokinetic properties and mechanism of actions, better to combine them to reduce the side effects and increase the efficacy. So that is called rational polypharmacy. And so some of the drugs, like already we had multiple drugs available broadly. Some are broad spectrum drugs, some are sodium channel blockers, some are confined to only one receptor like levetiracetam, SVA related. So better we can try to use drugs with different mechanism of actions to increase the synergism and decrease the side effects. So these are the drugs which can cause different kinds of effects on the liver enzymes. We should be aware which can cause synergistically, they can increase the metabolism. So better to avoid when you are giving different kinds of same mechanism of action. So I will not be able to cover all these individual things, but you can go through the slides I can provide. So after the rational polypharmacy, we have another option, that is ketogenic diet, but the ketogenic diet is one of the palliative thing only, it is not a curative thing. However, it is efficacious in 50% of the patients to reduce the seizure frequency. It is basically a high fat, low carbohydrate and restricted protein diet, and especially given in children with refractory epileptic encephalopathies. And so the different studies have shown that, systematic studies have shown that almost 50% will have 50% reduction with ketogenic diet. So this is the one of the last option that we try in children with epileptic encephalopathies. And pregnancy and drug resistant epilepsy is one of the other problem that we face, especially because of the teratogenic drug side effects of the medication. Managing the patients with pregnancy and drug resistant epilepsy is very challenging, and most of the times the best thing is, if possible, if any epileptogenic lesion is there, better to go for surgical option and make the patient to monotherapy, and then only advise them to go for pregnancy. But sometimes patient may not be a surgical candidate and they may not have time to undergo all these things, so it will be really challenging. And as you know, as polypharmacy causes a high frequency of teratogenicity. If it is monotherapy, around 3%, and once it is dual, it is almost 7 to 8%, and polypharmacy can be more than 10%, can lead to teratogenicity. So what are the things that specifically we should look at the pregnancy is mainly the dosages needs to be adjusted, especially during physiological changes during pregnancy. There may be change in pharmacokinetics. So you need to increase the anti-seizure medications by monitoring the therapeutic drug levels in pregnancy, and choose the drugs appropriately, and try the only one drug with maximum dose, and gradually, if suppose it is not possible to control on one drug, and if seizures are non-disabling, non-generalized, still we can manage on monotherapy. But if it is uncontrolled with one medication, sometimes we still give polypharmacy with explaining the risk, and they need to undergo proper antenatal checkups to find these abnormalities and go for termination. And generally, if you are giving, better to give like lamotrigine with levetiracetam is one of the combination that is relatively safe in pregnancy, and which can cover both focal and generalized epilepsies. So some newer drugs like cannabidiol has come into the market in the last 2-3 months, and this is one of the drug that has effect mainly in epileptic encephalopathies, especially Lennox-Gastaut syndrome and other epileptic encephalopathies where children have daily seizures. And this is also not a wonder drug, but 50% of patients have decrease in 50% in multiple studies. So the dose given is around 20 mg per kg, and after that there are some things that are already have come up, and that is mainly advances in the genetics. We could identify specific channels that are responsible for the epilepsy, and with the identification of these things, nowadays we are able to give precisely and avoid some drugs in particular subset of patients, and avoid or select the drugs in some subset of patients. That's called precision medicine. And some of the things that are identified with genetics are like sodium channel blocker should not be given to Dravet syndrome patients. That is because of the SCN1A mutation, and ketogenic diet is very useful in patients with GLUT1 deficiency. And you know, the vitamin responsive epilepsies, all these can be identified in children with refractory epilepsy. And if you can identify specific vitamins replacement can help the children significantly, especially pyridoxine and biotin responsive epilepsies are very well described, and they can be tried when neonatal onset seizures are there. So this is the future that may help in management of refractory epilepsy in future. And so I summarize this talk with so we should know that refractory epilepsy is seen in 30% of patients, and still these 30% only 15% will be eligible for surgical options. So another 50% again we need to manage with different medications, combinations, permutations, and then palliative measures. But one thing is that we can help all these patients at any stage by carefully looking into all these factors and selecting the drugs and adjusting the dosages, and taking care of the different triggering factors, and which are the worsening factors. If you spend some half an hour time definitely at each visit, when patient comes with refractory epilepsy, some or other point we will be able to pick up and help them to improve their quality of life. So don't give up, and still many patients can be helped with various medication adjustment and as well as palliative things. And in case if it is suitable for surgical option, that next speaker will be talking about how to evaluate the patients pre-surgically and how to take up for surgery. But still medical management helps patients to improve the quality of life. Even though we cannot cure them, we can improve their outcomes by all these measures. Thank you organizers once again for this opportunity.
Well, the okay. Whereas the emphasis rightly today is on the other end of the spectrum of epilepsy patients, it is very important when the patient comes to you not to overdiagnose epilepsy. This is a frequent problem, so much so even in epilepsy surgery centers who come with a label of resistant epilepsy, at least fully 20 to 30% of them are found to have no epilepsy. So the most important test in epilepsy patient and in any neurology patient is an adequate history and retaking the history. And whenever you have doubt, you must revise your diagnosing, and at least you should not admit to yourself you have made a mistake and change your diagnosis.
Thank you, Dr. Rina, for a wonderful explanation of drug-resistant epilepsy. This same time, I have a general question as to any condition. I'd like to have your opinion regarding driving. You touched about pregnancy and epilepsy. What about driving and epilepsy? Can you just enlighten us a little bit? What is your views and
Yeah.
your recommendations? Because that's a big problem.
Yeah.
You see drivers coming with epilepsy, driving, confirmed drivers of
Yeah.
bus, and if so many lives that they stake.
Yeah. So, driving in epilepsy is one of the important thing that everybody should be aware. Unfortunately, there are no strict guidelines, and our laws are not very strict for this very dangerous situation in the country. And the unfortunate thing is, when we go for driving license, nobody asked me whether I am epileptic or not, and most of us get driving license without any medical examination. And many of the truck drivers still drive on our highways with epilepsy. So it is very scary to go onto the road. We don't know who gets seizure at any point, and then it may be dangerous even though if we are careful. But the strict thing is that nobody should drive with epilepsy is the main thing, especially public transport you should not drive. That is the personal recommendation. And always whenever we see patients, always ask their occupation, and if they are involved in driving, we should educate them. And but when seizures are very infrequent or they are compliant to the medication, 100% we cannot tell them you don't drive at all, because for some people, if it is well controlled for 10 years and all lifetime, we cannot ban them, because that may deprive them of their employment and other things. So that at individual driving at some limited risk with seizures are well controlled and they are very compliant with one medicine, maybe personally okay, but public transport 100% no, and they should be aware about their situation and they should be cautious about this thing. That's my personal opinion.
Thank you. Now the thing is open to discuss. Any questions from the audience?
Sir, I have a question. Few years back, we were using phenytoin a lot.
Yeah.
In neurosurgical practice, we were using for the prophylaxis for post-traumatic diseases. Whereas I saw that in your slides that is
Phenytoin is still used, there is no doubt about that. Only problem that when you use for long term, and if you are seeing patients of very long standing epilepsy on phenytoin, the moment you see their face, you can tell that this person is on phenytoin. So the facial features will become coarse and bones will become weak, and excessive facial hair, gum hypertrophy. So these are all some kind of things which can be avoided with better pharmacokinetic and other newer drugs which have come up. But still for short duration, and when especially that is the preparation which has IV preparation, one of the few drugs which has IV. So we can still use for loading in status epilepticus, and for 6 months to 1 year it's not a major problem. But beyond that, if we continue to give, the side effects are not acceptable at present, because we have better drugs with less side effect profile. So I generally don't prefer to give longer time phenytoin. That is the thing.
There are many neurosurgeons who may add more to this, but for short-term post-surgical use, where we use only for a few weeks to month, Epton is good enough, though there are studies which prove that levetiracetam is equally effective. And going back to one of the earliest population studies done in India, in Gauri Bidnoor by one of our revered epileptologists from Nimans, Dr. Mani, first time diagnosed, first time treated patient, about 60% respond to any of the 3 drugs which were that time available in 60s, phenobarbital, phenytoin, or carbamazepine. This is very, very encouraging. So where there are situations you cannot get advanced consultations, advanced treatment possibilities because of cost or availability factors, especially people who are posted in rural settings or go to do any rural visits, any of the 3 drugs, phenobarbital, phenytoin, carbamazepine, as a first line drug, 60% become all right. There are several conditions in which it is contraindicated. In usually selected doses, it should not be harmful to put these patients on these 3 drugs. I was very pained to see that phenobarbital was in the long but one of the list of our epileptologists here. But phenobarbital is a very fine drug. Previously in 60s and 70s, we had only phenytoin, phenobarbital and carbamazepine. And patients did very well. And even today, many people come to us with phenobarbital and eptine combination. And now they have banned it and it is not available. That's another problem. They were very well controlled. And we had a tendency to stop that and make it single dose treatment as advised in the textbooks. They were not tolerating it. So whatever they are tolerating, they are doing well, don't change it. Combinations are also okay as long as they don't have side effects.
I agree with sir that phenobarbital is really a wonder drug, especially for our country. Still, most of them, when seizures are infrequent or medically manageable, well-controlled epilepsies can be managed with any drug. Since it is single dose drug, and compliance also will be very good and side effects are less. So phenobarbital is one of the drug that can be considered. Even in refractory also, after trying all these newer drugs, I still add one cycle phenobarbital whether it will help. I see few patients respond to that. So it should not be forgotten. That's important thing.
Any other questions from the audience? Yes. Yeah. Go on to the. Thank you very much, Dr.
Thank you.
Thank you so much, Dr. Ravindranath, for that session. I now invite Dr. Divya and Dr. Nitya to give the invocation song.
ನಮ್ಮಮ್ಮ ಶಾರದೆ ಉಮಾ ಮಹೇಶ್ವರಿ ನಿಮ್ಮೊಳಗಿಹನ್ಯಾರಮ್ಮ. ನಮ್ಮಮ್ಮ ಶಾರದೆ ಉಮಾ ಮಹೇಶ್ವರಿ ನಿಮ್ಮೊಳಗಿಹನ್ಯಾರಮ್ಮ. ಕಮಗೊಲನ ವೈರಿಸುತನಾದ ಸೊಂಡಿಲ ಹೆಮ್ಮೆಯ ಗಣನಾಥನೇ ಅಮ್ಮಯ್ಯ. ನಮ್ಮಮ್ಮ ಶಾರದೆ ಉಮಾ ಮಹೇಶ್ವರಿ ನಿಮ್ಮೊಳಗಿಹನ್ಯಾರಮ್ಮ. ಮೊರೆ ಕಪ್ಪಿನ ಭಾವ ಮೊರೆದ ಗಲದ ಕಿವಿ ಕೊರೆದಾಡಿವನ್ಯಾರಮ್ಮ. ಮೊರೆ ಕಪ್ಪಿನ ಭಾವ ಮೊರೆದ ಗಲದ ಕಿವಿ ಕೊರೆದಾಡಿವನ್ಯಾರಮ್ಮ. ಮೂರು ಕಣ್ಣಿನ ಸುತ ಮುರಿದಿಟ್ಟ ಚಂದ್ರನ ತೀರದ ಗಣನಾಥನೇ ಅಮ್ಮಯ್ಯ. ನಮ್ಮಮ್ಮ ಶಾರದೆ ಉಮಾ ಮಹೇಶ್ವರಿ ನಿಮ್ಮೊಳಗಿಹನ್ಯಾರಮ್ಮ. ಉಟ್ಟದಟಿಯು ಬಿಗಿದುಟ್ಟ ಚಲ್ಲಣದ ದಿಟತಾನಿವನ್ಯಾರಮ್ಮ. ಉಟ್ಟದಟಿಯು ಬಿಗಿದುಟ್ಟ ಚಲ್ಲಣದ ದಿಟತಾನಿವನ್ಯಾರಮ್ಮ. ಬಟದ ರಾಣಿ ಪಾರ್ವತಿಯ ಕುಮಾರನು ಹೊಟೆಯ ಗಣನಾಥನೇ ಅಮ್ಮಯ್ಯ. ನಮ್ಮಮ್ಮ ಶಾರದೆ ಉಮಾ ಮಹೇಶ್ವರಿ ನಿಮ್ಮೊಳಗಿಹನ್ಯಾರಮ್ಮ. ಕೊಮಗೊಲನ ವೈರಿಸುತನಾದ ಸೊಂಡಿಲ ಹೆಮ್ಮೆಯ ಗಣನಾಥನೇ ಅಮ್ಮಯ್ಯ. ನಮ್ಮಮ್ಮ ಶಾರದೆ ಉಮಾ ಮಹೇಶ್ವರಿ ನಿಮ್ಮೊಳಗಿಹನ್ಯಾರಮ್ಮ. 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 ಥ್ಯಾಂಕ್ ಯು.
I now invite all of our dignitaries, our principal, Dr. Sridhar Venkatesh, Dr. Anand Kishan, Dr. P.C. Mohan, Dr. Ravindranath, Dr. Malabhaskar, and Dr. Natraj to please join us on the dais for lighting of the lamp. Please take a seat on this dais. Welcome to our principal, Dr. Sridhar Venkatesh. Thank you so much for gracing us with your presence today, sir. Thank you to Dr. P.C. Mohan for joining us as well. Thank you, Dr. Malabhaskara, for please taking your time and spending it today with us. Thank you to Dr. Ravindranath for taking your time and making this very enlightening presentation for us today. And thank you for Dr. Natraj for taking his time and coming today. Thank you to our organizing chairperson, Dr. Anand sir, for supporting us through this journey. I now request Dr. Anand Kishan, HOD and Professor of Department of Neurosurgery, to welcome the gathering.
Good morning, everyone. After invoking the blessings of Almighty, I'd like to pay my respects to our founding chairman, Sri Adikeshulu, our former chairperson, Srimati Satyaprabha Adikeshulu, and extend warm greetings to all of you from our current chairperson, Srimati Kalpitra Dalwai, and advisor, Dr. Mahesh Kottapalli. Dignitaries on the dais, our principal, Dr. Sridhar Venkatesh, Dr. Malabhaskar Rao, Professor of Neurosurgery from NIMHANS, Dr. Ravindranath, Additional Professor of Neurology from NIMHANS, Dr. Natraj, Honorary Professor of Neurology at Vydehi, and Dr. P.C. Mohan, Professor of Neurology at in our hospital. It gives me great pleasure to welcome you all to this deliberation regarding epilepsy and to explore more possibilities to manage this big problem. We all know that epilepsy is a very ancient and intriguing ailment which has been afflicting mankind since times immemorial. And it continues to be a very common and challenging problem affecting almost 50 million people around the world today. Epilepsy can affect anyone, right from a beggar to an emperor. And we know that very famous people like Beethoven, Alfred Nobel, Napoleon Bonaparte, Theodore Roosevelt, Edgar Allan Poe, Agatha Christie were all, and even currently Elton John and so many were all suffering from, are all epilepsy patients. So it is a big problem and doesn't spare anyone. In the past few decades, as we have already seen with our previous speakers, there have been tremendous advances both in the diagnostic modalities and in the therapeutic modalities of managing various neurological and neurosurgical problems. But despite that, we have severe, great problems like epilepsy. And today, with all our deliberations, I hope we can learn more about managing these from our stalwarts in epilepsy. I once again welcome all of you and hope you all enjoy this session and actively participate and learn from this session too. Thank you.
Thank you so much, sir. I now request our principal, Dr. Sridhar Venkatesh, Professor and Department of Obstetrics and Gynecology, to address the gathering.
A very good afternoon to everybody here, especially the dignitaries on the dais, off the dais. Apologies for the delay caused by us, and I bring in the greetings from our chairperson, Madam Dalvai Kalpaja, and our advisor, Sri Mahesh Kotapalli. It's indeed a pleasure to be seeing a CME of this particular disease, epilepsy, being organized by the Neurosciences Department of Neurosurgery and Neurology. Very interesting topic though. Affects almost all branches of medicine, and epilepsy, the nuances are to be learnt and discussed in a platform like this to improvise and make better the treatment and management of the disease. I think it won't be out of place if I just take a minute and mention an experience of my own. I have a receptionist in my clinic I had, who was a person who was sitting in the front desk, and I used to get complaints from patients that she makes dirty faces at them. And this used to happen on there was a pattern. Regularly some patients used to come and say, she's all right. Some say she makes a dirty face at us. So we used to reprimand her a couple of times. And then somebody suggested that you see what she's doing. So those days there were no cameras, of course. So I managed to see her once and felt there's something abnormal. So I referred her to a physician who referred her back to a neurophysician. And it was found to be an epileptic attack that she was having. Nothing, no body movements at all. She's just sitting in the reception counter and making some facial expressions were changing. That is all that epilepsy, and that's how intriguing this disease can be. I think it can beat any of the best physicians in town. So there's a lot to learn and a lot to understand from these CMEs and meetings, more so on the occasion of the International Epilepsy Day. And being an obstetrician, again, it's more great interest to us because we were struggling to counsel patients to conceive or not to conceive. If conceived, what medications to be taken, of course, safe for the fetus, and all these things. So there are a lot of information to be gained by all the stalwarts gathered here today. And I wish this session good and fruitful completion. Thank you.
Thank you, sir, for those inspiring words. I now request all the dignitaries to take their seats among the audience. As mentioned before, the International Epilepsy Day is held every year on the second Monday of Feb. And this year, in view of the International Epilepsy Day on February 12, 2024, a poster competition was held for our undergraduate students. 20 posters were submitted by over 150 students, and out of these, 2 posters have been selected as first prize and second prize. So we would like to award these students here today. I request our principal, Dr. Sridhar Venkatesh, to please award the winners of the competition.
You already announced it. Come out. Come. Do it here only. 12 people are there.
Okay.
We can do in front only, in the below. Come. There are 12 students each. I think she has already announced that they could have been sitting only.
The first prize winners in Group 1 are Harika Archana Raj,
Come and stand there.
Trisha C, Yashika,
Prize
Lincoln, Praveen Rai, Chama, Chandana, Gangana, Kush Tripathi, Unmesha, and Shrena.
Archana, sorry. Yeah, Archana. Yeah. Yeah. And you can just give it to your. That's good. Good. Congratulations. Hello. No, poster. They all put the posters out, so we'll show it to you afterwards. Oops. No, it's not like this.
We now have our second prize winners, Akela, Aishwarya, Arush, Adit, Shubhashri, Aditya, Asif, Akash, Abhishek, Afzal, Adrija, and Ayman. Please make your way to the stage. Thank you, sir. Thank you to all the students who have put in their efforts. We appreciate it. We invite all our attendees to keep an eye out for their posters that are displayed in the corridor. We will now continue with the second session. We would like to introduce our next speaker, Dr. Anand Ji.
Dr. Anand, Professor of Department of Neurosurgery, a highly accomplished and skilled neurosurgeon with over 10 years of extensive experience, having completed his MS degree at prestigious Bangalore Medical College and Research Institute and residency in neurosurgery from Nathiba Hargovandas Lakshmi Chand Municipal Medical College, Ahmedabad, Gujarat. Dr. Anand is also specialized in spine surgery and minimally invasive techniques, including ventricular and transnasal skull-based surgeries. Beyond his clinical practice, Dr. Anand has made a significant contributions to the field of neurosurgery through his research and publications in reputable journals, and has also devoted many years into teaching the younger professionals in neurosurgery. We welcome you, sir. Over to you.
Thank you. That was a pretty endearing introduction, which even I didn't expect. So good afternoon, everyone. So when I was asked by my professor and HOD, Dr. Anand Kishan, to talk about a topic, and the topic was preoperative evaluation for epilepsy, it was a kind of dual feeling. So one, I was happy, yes, so I'm going to talk about a surgical aspect. But then the other aspect was, how often am I exposed to this aspect? As a neurosurgeon, when I'm dealing with epilepsies, the common thing that I do is lesionectomies, lesions diagnosed, come to us with an EEG picture. We try to correlate the lesion with the EEG picture, and then finally we do a lesionectomy. And we routinely tell the patient there might be a possibility of control of seizure, or there might not be. So this is the routine practice that we do. So it was like literally an eye-opening experience when I started going deep into the topic. For the past 1 week, my daughters have been asking me, Nana, why have you been reading so much? I was like, this is a domain that I'm not routinely exposed to other than the lesionectomy side. So this is kind of a learning experience for me, and this presentation is actually from this perspective, my own perspective of how I understood the subject at the resident level, basically. So we have already had extensive sessions about the diagnosis, the different conditions, like the medical management, the radiological aspects. So straight away jumping to the surgery. Candidates for epilepsy surgery must undergo a thorough pre-surgical evaluation to know whether they can actually benefit with surgery or not, and whether we can stop seizures. So my presentation will be focusing on these aspects: the goals of testing, which tests and why, a bit more about each test, and then something called phase 1 and phase 2 evaluation. Surgical decision making, I actually thought I would dwell upon, but then again I felt, who better than Dr. Malabhaskar sir himself to talk about that, so I'll restrict myself to only these 4. So indications for surgery. So there are multiple factors which govern the necessity for surgery in epilepsy patients, including the pathology, the seizure semiology, and the clinical characteristics of the patient. Common indication, or one of the most common indications other than structural lesions, today's topic is drug resistance epilepsy. So as per ILE consensus, whatever the definition of drug resistance epilepsy, which has already been discussed, so it becomes one of the most important indications. And then the structural lesions, when the seizure semiology shows characteristic clinical localization, and disabling epilepsy. Here, this is one aspect which is kind of dicey because patient will decide what is actually disabling for him, and if the patient wishes, then we need to offer surgery. Contraindications: concurrent severe active psychiatric illnesses where we really don't know whether surgery is going to benefit the patient or not, severe medical comorbidities precluding any surgery, and then if there is a failure in identifying the epileptic foci in spite of extensive investigations. Frankly, these become relative contraindications because even if we have failed to identify the epileptic focus, there are certain indications for surgery, for example, corpus callosotomy in repeated drop attacks, which will be a palliative procedure. So coming to the first aspect of my presentation, goals in pre-surgical evaluation. First thing, why do I need a pre-surgical evaluation? To determine whether the patient is eligible to be operated or not. Next, once we decide to operate on the patient, mapping the extent of the epileptogenic zone and its possible overlap with clinically testable functional regions, that is, the adjacent important structures and the relationship of the epileptic zone with the adjacent structures, the connections, which form the anatomo-electroclinical network. So that is the second thing. We have to comprehensively map, accurately and comprehensively map the AEC network along with the epileptogenic zone. Why? When we do this thoroughly, we can achieve a complete resection because that is actually the target. Because if we leave behind even a small focus, there is always a possibility of recurrence. So our target will be complete resection or disconnection of the cortical areas or networks responsible for the generation of seizures, and to reduce the risk involved in surgery. What are the risks involved in surgery other than the surgical related complications? The damage to the neighboring important functional areas. So, identify the epileptogenic zone, neighboring adjacent areas. These will be the primary foci when we are evaluating a patient for epilepsy surgery. It is area of resection, that's a problem area of preservation, the neighboring functional brain. So here just a small picture. If this is an epileptogenic lesion, we have something called epileptogenic zone, and we have something called the irritative zone. We have the eloquent cortex. This is just a pictorial representation to understand things. Symptomatogenic zone, which gives actually the seizure semiology to us, and then functional deficit zone. So now coming to the different techniques that we use for pre-surgical evaluation. Broadly, the techniques that we use for pre-surgical evaluation in epilepsy are categorized into phase 1 and phase 2. Phase 1 involves non-invasive techniques. Non-invasive techniques, electrophysiological tests, routinely the EEG that we do, video EEG and ictal and interictal EEGs, magnetoencephalography. Coming to imaging techniques, high resolution MRI, PET scans, SPECT scans, functional imaging and tractography. And then we have an important aspect called neuropsychological testing. Then the second phase will be invasive techniques. Invasive techniques where we introduce electrodes directly into the brain. There are two types of electrodes, stereo EEG or CEEG, that is, which are introduced by craniotomy. So what is the purpose of invasive techniques? For invasive EEG recording, brain mapping, and intra or extraoperative electrocorticography. So yeah, it kind of feels too much to take in, but anyhow, I'll try to go gradually one by one so that we can understand at least to a certain extent, or at least I will say what I could understand out of that. So coming to non-invasive techniques, this anyhow routinely we see in a clinical practice. So video EEG and interictal EEG. So before that, as I mentioned previously, we do something called a recording of seizure semiology. So Dr. Ravindranath beautifully displayed us some recordings of how the seizures can be. So the video recording of seizures is a very important aspect to understand the kind of seizures that we are dealing with. So semiology also includes the presentations. For example, we don't have a video recording. So the symptoms from the patient, or when we are yourself examining the patient, the signs and symptoms other than the recordings are very important to understand the nature of the seizure that we are dealing with. Then comes the electroencephalogram. So video EEG, a very important aspect. So in the videos that Dr. Ravindranath was showing, we were seeing that most of the patients had electrodes attached to them. The electrodes were attached and patients were simultaneously being recorded by the video. So video EEG is one of the important aspects in understanding the seizure semiology. So it's helpful to determine if seizures with unusual features are actually epilepsy or they are not, to identify the type of seizures and to pinpoint the region of the brain where seizures begin with. So because he was describing that each seizure, the area of origin describes the seizure semiology in the presentation. So on that basis we can actually identify the area of origin of the seizures. So it's also called EEG telemetry or EEG recording. It can be done at home or in the outpatient setting like an EEG lab. At home, really difficult for the infrastructure to be shifted there and done. So EEG lab is the most common area where we do video EEG. So this is just a representation, patient with electrodes attached. Then we have the EEG recording here. We have a video which simultaneously displays things. So intellectual epileptogenic activity in a mental and neurologically normal subject in an appropriate clinical context has a high positive predictive value for the diagnosis of epilepsy. Basically, in simple words, we see EEG, some classical features on EEG that we have. So for example, spike dome, all those things. So those have very high localizing value. So video EEG and intellectual EEG helps classify whether a focal or generalized seizure disorder is present. It assists in defining specific syndromes like Rolandic epilepsy, childhood absence epilepsy, and Lennox-Gastaut syndrome. We have also something called HD EEG, high definition EEG. Routinely in EEG that we use on outpatient basis, we have hardly some 64 electrodes that we have. Whereas in high definition EEG, this can be increased up to 250 leads. So we have ultra high definition picture of the electrical activity, so which helps in highly localizing the lesions. So there is something called HD ESI, high density epileptic source imaging, which includes HD EEG plus MRI superimposition. So this gives a beautiful localization of the lesion when both of these are superimposed. Now comes magnetic encephalography, or it's also called, there's something called magnetic source imaging. So the basic principles of magnetoencephalography. So whenever there is an electrical activity, there's always an associated magnetic activity. Electrical activity and magnetic activity will be in perpendicular fields to each other. This is a simple physics there. So even brain has electrical activity going on. So where there is electrical activity, we have magnetic activity. But the magnetic activity generated by the brain is very, very minute, to the level of 10 to minus 15 Tesla. Whereas Earth's gravitational force is around 10 to minus 5 Tesla approximately. So now, if we have to test the magnetic activity of the brain, this magnetic activity of the Earth has to be negated. So, which means we have to keep the patient in a room which doesn't have significant magnetic activity from the Earth, contributing to what is called the noise in interpretation. So this needs an extensive setup, a very costly setup, and costly equipment and separate setup for that. But it's a great investigation. So again, magnetic source imaging is MEG plus MRI together. So MEG is a direct neurophysiological technique for studying the brain based on measuring magnetic fields primarily associated with the summated postsynaptic intradendritic electrical currents. So here we test dendritic currents, not the axonal currents. So this is a setup already displayed by the previous speaker. So benefits of MEG and MSI. With regard to seizure focus, so as I said, I basically classified all the investigations as to how they are going to help us in two things: how to identify the seizure focus and how do they help us with the neighboring structures. So when it comes to use with regard to seizure focus, MEG provides intellectual recordings and identifies an irritative zone. It helps in localizing eloquent cortices of interest non-invasively in patients without structural abnormalities. Establish spatial relations of the lesions with eloquent cortices. So basically it helps us in identifying eloquent cortices and the epileptogenic zone and we try to sync these two and try to identify the pathology and the neighboring zone so that we have a very clear picture of the lesion that we are dealing with. So when it comes to use with regarding to functional area, MEG provides evidence for and also distinguishes between epileptogenic and non-epileptogenic lesions in case of several or diffuse lesions, and it helps in non-invasive motor and sensory mapping. Usually MEG is always done together with EEG. So that was in brief about the electrophysiological tests that we have, that is EEG, video EEG and MEG. Now coming to neuroradiological evaluation for epilepsy surgery. It has always been covered extensively, it has already been covered extensively in the previous talk. I'm just going to brush through some basic things. So magnetic resonance imaging. Is MRI done in all cases of seizures or epilepsy? No, there are certain indications. Onset of partial seizures at any age. The onset of generalized or unclassified seizures in the first year of life or in adulthood. A fixed deficit on neurological or neuropsychological examination, which is a very strong indicator that there is a definitive pathology in the brain which needs to be evaluated. Difficulty in obtaining seizure control with first-line anti-epileptic drugs, or loss of seizure control or a change in the pattern of seizures. These become routine or common indications for getting an MRI scan done. So here we are talking about something called structural MRI. That is a routine MRI that we talk. We'll name it as, we call it structural MRI because it gives us the structural details of the lesion and the brain. So the common lesions that we see, this interests me as a neurosurgeon because this is what I'm routinely dealing with. We have tumors, vascular malformations, hippocampal sclerosis, malformations of cortical development. In brief, tumors, any tumor can be a possible cause of seizure. 70% of the cases they are located in the temporal lobe. The common epileptogenic zones will be in the frontal and temporal lobes predominantly, not that parietal and occipital cannot be. So, young adults and children, most common tumors associated with epilepsy are something called DNETs and gangliogliomas. So, here MRI picture, here we have a DNET, ganglioglioma. The features have already been discussed in the previous discussions, I'm not going to dwell too much on them. A low-grade glioma, and here we have a popcorn lesion, which is actually a cavernoma. So, it's a vascular lesion. So vascular malformations are other kinds of vascular lesions that can cause seizures. Up to 25% of the cases, arterial malformations can present with seizures. But the best investigation for vascular malformations is usually an angiogram. But cavernomas, MRI is always a very good investigation to identify things. Then hippocampal sclerosis, one of the most common pathology that we see in seizures, uncontrolled seizures. So this has already been described in the previous section. Again, I'm going to tell the same thing. So in T1 sequences, we have thinned out hippocampus, and in T2 sequences, we have hyperintense signals there. Also, there are some associated changes that has already been described again in the previous session. Just briefly, features associated with hippocampal sclerosis will be temporal horn dilatation on the side, and also the atrophy of the structures that form the outflow tracts from the hippocampus. The neighboring cortices, which the hippocampus is connected to, will be atrophic, and even the white matter fibers will be less when we see on the MRI. So now coming to malformations of cortical development. These are usually classified into 3 groups. Group 1 will be abnormal, malformations of abnormal proliferation. Group 2 will be malformations of abnormal migration. Group 3 will be malformations of abnormal reorganization. So again, briefly, tuberous malformations of abnormal proliferation. Tuberous sclerosis is one of the most commonly diseases that presents with multiple tubers or hematomas. So here we are seeing multiple tubers in the ventricular side, and then we have hemimegalencephaly, wherein one side of the hemisphere is enlarged with associated ventricular dilatation. This has already been dwelt in the previous discussion. So malformations of the cortical development, group 2, that is abnormal migration. We have something called lissencephaly, which means smooth throughout brain, that is the sulcal gyral pattern is reduced. And then we have something called heterotopias, which is abnormal deposition of grey matter other than the place where they are supposed to be. So here we are seeing nodular depositions in the white matter, and it can be either nodular or it can be band-like deposition. Then we have malformations of cortical development type 3, that is abnormal reorganization, polymicrogyria and schizencephaly. This is an example of schizencephaly, wherein you have a ventricle communicating with the cortex. But then, how do we differentiate this from something called porencephaly? In schizencephaly, we have gyral pattern seen along the cleft, whereas in porencephaly, we see only white matter along the clefts. So this is briefly about malformations of cortical development. Focal nodular dysplasias are also amongst these. They are usually type 1 and type 2. Now, this also was developed in the previous section. Whenever there is a seizure, there is a possibility of certain changes that can be picked up on MRI. And these are usually transient. So, sometimes immediately post seizure, the brain may show some T2 weighted hyperintensities. So, it's always better, which might be confused for some lesions. So, it's always better to repeat imaging at a later date when the patient has been seizure free for a reasonable period of time. Now, MRI sequencing, the different sequences, how do they help in characterizing the lesions? Volumetric T1 weighted images, disorders of cortical development. T2 weighted images, hippocampal architecture and cystic tissues can be identified. Coronal flare images and three-dimensional phase sequences help in identifying hippocampus sclerosis, tumors, inflammations and scars. And gradient echo sequences usually help in identifying calcifications and vascular lesions. So when all these put together are done with our MRI, we have the diagnostic accuracy of up to 99.5% in identifying structural lesions. So role of MRI in non-lesional assessment. Can MRI, structural MRI, help in non-lesional assessment? May not be directly, but possibly in an indirect way. So for example, there seems to be a relationship between hippocampal volume and memory dysfunction. So greater hippocampal volume, possibly greater memory dysfunction. Patients with temporal lobe epilepsy have a more global reduction in the volume of cerebral tissue. Reduction in volume of white matter is strongly associated with cognitive impairment. So one more thing, amygdalar volume also may be an important aspect. When there is an increased amygdalar volume, patient may have depression and psychosis, and when there is decreased amygdalar volume, patient may have interictal aggression. So these structural changes in non-lesional areas can be indirectly assessed by MRI. But of course, this is not going to be really of great significance when we have other beautiful imaging techniques in radiology. Coming to functional MRI, I'm not going to dwell much on this, but functional MRI is one of the most important aspects of evaluation of seizures in current day practice. It is used to map language, motor function, memory, and epileptic activity. When an MRI, functional MRI is superimposed with electroencephalography, we get what is called EEG fMRI. This has the advantage of combining high spatial resolution of functional MRI with excellent temporal resolution of EEG. So it gives a very beautiful localizing picture of epileptogenic zone and also the functional areas of the brain. But the limitation is there is a requirement for epileptiform activity during the scanning. So if we don't have this epileptiform activity during the scanning, then this might not really work out for us. But if it is, then it has a beautiful localizing value. Then diffusion weighted images. We are more interested in tractography when we are dealing with diffusion weighted images. Tractography is a 3D modeling technique used to visually represent nerve tracks from diffusion MRI. There are certain nerve fibers, white matter fibers, which are of paramount importance when we are dealing with epilepsy surgery. There are certain fibers called uncinate fasciculars, inferior longitudinal fasciculars, superior longitudinal fasciculars, and there are Mayer's loop, etc., which have to be identified, particularly when we are doing lesionectomy in epilepsy surgeries, and also disconnection, because any damage to these important white matter fibers can lead to the corresponding deficit. So these have to be identified other than the lesion and the eloquent areas. So white matter fibers are also of very great importance in identification, to be identified when we are doing epilepsy surgeries. Now comes magnetic resonance spectroscopy, predominantly used for tumors. Then we have something called interventional magnetic resonance imaging or intraoperative magnetic MRI. This has already been dealt with. So one greatest advantage of intraoperative MRI is we have a real-time assessment on table whether the tumor, the resection that we have done is really complete or not, particularly when it is integrated with intraoperative EEG and neuronavigation. Then the overall results are really amazing in terms of the extent of resection that we can achieve and also the preservation of adjacent tissues. Then comes SPECT. SPECT again is a radionuclide study. So SPECT is an imaging technique that assesses cerebral blood flow by deposition of a metabolized radiopharmaceutical in the brain. So, but basically this test utilizes the increased flow into a particular part of the brain when that part of the brain is being utilized, and the metabolite goes and gets deposited in, and this is picked up on the scanner, and this helps in localizing. So SPECT is sometimes used to localize seizure onset in non-lesional cases. It is a most valuable tool in lobar localization and hemispheric lateralization. So in non-lesional cases, when we are not able to identify anything on structural MRI, then probably SPECT can help us in identifying the lesion. So we have something called subtraction images. So this is an interictal SPECT and this is an ictal SPECT. So when these two images are subtracted, then we get something called a subtracted image which has good localization of the epileptogenic zone. So an extension of SPECT will be something called SysCom, wherein the subtracted images, that is the ictal and interictal subtracted images, will be superimposed on patient's MRI so that we get a highly localized, this has high localization value in terms of identifying the lesion. We have a metabolically active lesion and we are superimposing on the patient's MRI. So this gives a very beautiful localization of the epileptogenic zone. So a further protraction of this will be something called StatisCom, wherein it involves the statistical comparisons between the patient's SPECT scan and a set of paired SPECT scans from normal subjects to analyze whether we are really dealing with the lesion or not. So this has a further enhancement of the localizing value of the SPECT scan. But then we are talking of interictal and ictal SPECT. So what will be the limitations of SPECT? It's a very time and resource intensive study. So there was a question raised, how do we do SPECT? How do we identify when the patient is having ictus? Because we have to very precisely time your scanning according to the patient's ictus. So that is exactly what is the problem here. Of course, centers which are highly equipped routinely do that, but even there, as it was already mentioned by Dr. Ravindranath, they wait, they see, possibly after 3 or 4 seizures, they get an idea, and then they go in for the final attack on the lesion, on the epilepsy, on the seizure basically. So, the limitations of SPECT. The radioisotope must be injected as soon as possible after seizure onset. And it is best suited for patients with long auras or seizure prodromes so that we know that the seizure is going to happen. And if there is a long delay in the injection of the tracer agent may dissipate into the neighboring zones rather than being focused in the epileptogenic zone. And one more disadvantage is SPECT often demonstrates more than one hyperperfused brain region, making interpretation difficult. So take home points from SPECT scan. It's a reliable and important imaging technique for lateralization and localization. So it is a technique which images the seizure itself, whereas the other techniques are usually interictal. And it is usually not alone sufficient imaging modality. It has to be usually used in association with other modalities, and the concordance is what is going to guide us. So finally, again summarizing the neuroradiological investigations. For lesion assessment, we have high resolution structural MRI, MRS, SPECT and PET scans. For functional brain assessment, we have functional MRI and tractography for both intraoperative MRI. Now comes the neuropsychological assessment. This is again one more important aspect, but then again neuropsychology is a totally different ball game. I am just going to go very superficially on this. We have different scales on which a patient's neuropsychological assessment is done. And then, see, neuropsychological assessment is an important aspect because we have to identify the different functions like memory, language functions and memory functions, which lobe, how significant, what contribution each lobe is making to these functions, and how we are going to preserve these when we are going to operate on epilepsy patients. We have one more test called VADA test, which helps actually for functional brain evaluation, particularly for memory and language functions. It involves VADA test. Just briefly about VADA test. Depending on the location of epileptogenic zone, resective epilepsy surgery frequently carries a risk of cognitive decline, and VADA testing is used to predict the nature and degree of this risk. So it primarily involves assessment of language and memory during the period of hemianesthesia. So basically, a lobe of the brain is hemianesthetized by injecting an agent, usually barbiturate kind of drugs, and then we have a comprehensive neuropsychological evaluation performed with regard to baseline language and memory, which aids in interpretation of language and memory performance during the period of hemianesthesia. That is, before hemianesthesia, we do a certain amount of evaluation of patient's memory and language functions, and during the period of anesthesia, we again analyze and we try to compare these two and see whether the test is causing any change or not. Because how does it help? I'll tell you. So usually the test goes on for 3 to 5 minutes, not more than that. So when the language dominant hemisphere is injected, the patient typically exhibits an initial speech arrest, but patient may still be able to vocalize. Say for example, patient's left hemisphere is dominant and we are injecting into the left hemisphere. So patient will not be able to move the right side of the body and he will not be able to vocalize, but he still will be able to perform functions with the left side of the body. Whereas if it is injected into the non-dominant hemisphere, so for example, right side is the non-dominant hemisphere, we are injecting into the right hemisphere, patient will be able to vocalize, verbalize and perform the functions. So this way we try to get to know which lobe is dominant and in which lobe, for example, if the lesion is in the dominant zone, dominant lobe. So in that case, we have to be more careful about the language and memory function. If it is in the non-dominant zone, then possibly language and memory dysfunction might not be really significant after the surgery. So interpretation of VADA testing is something called pass versus fail. If the patient passes a recognition memory testing for items that were presented during ipsilateral hemianesthesia, it is taken as an evidence that the contralateral temporal lobe has adequate learning and memory capacity, and thus the patient has passed the VADA test. So basically, contralateral, so ipsilateral hemianesthesia causing, so basically that's what, as I have already described, let me not confuse things there. So dominant hemisphere, if we are injecting, then patient is having more language and memory disturbances. Non-dominant hemisphere, if we are injecting, patient will not have this, and this is how we try to interpret VADA testing and this is how it helps us in formulating our surgical decision making. So that was in brief about VADA testing. So now, inclusion of VADA testing in the evaluation of epilepsy surgery has decreased considerably over the years, because there have been advances in neuroimaging which have led to increased efforts to develop non-invasive alternatives. So nowadays, the most important non-invasive alternative that we have been using in place of VADA is the functional MRI. So numerous studies have aimed to develop functional MRI protocols to lateralize language and predict post-operative memory with the ultimate goal of replacing the VADA procedure. But it's not that VADA is totally obsolete. Possibly it can be used in pediatric age groups. So finally, as I said, VADA is predominantly used for testing language and memory functions on the dominant side. Okay. Now, enough of VADA. Coming back to the evaluation sequence. Finally, summarizing the phase 1 sequences that have discussed till now. For localization of the lesion, so I had told in the beginning itself, so I am summarizing my investigations into 2 categories. One, for localization of the lesion, and for the localization of the neighboring structures. So when it comes to for localization of the lesion, when we are doing evaluation for epilepsy surgeries, we'll go for first a high resolution MRI, then a video EEG and detailed neuropsychological assessment. After these basic investigations, if there is any ambiguity regarding localization, then we go for the additional set of investigations. And now I have told you there is something called the irritative zone and the ictal onset zone. So ictal onset zone is the primary area and the irritative zone is the area around that. So if there is any ambiguity in localization with the initial 3 investigations, that is high resolution MRI, video EEG and detailed neuropsychological assessment, we go to the next rung of investigations for ictal onset zone, that is ictal HDEEG, ictal EEG fMRI or intrictal PET and SPECT scan. As I have already described, high density epilepsy source imaging with fMRI has very high localizing value. So when we are not able to identify with the initial set of investigations, these set of investigations will help us in identifying the ictal onset zone. For the irritative zone, the same we do in intrictal phase, that is intrictal HTEG and intrictal MEG and intrictal EEG fMRI. For functional area preservation or the identification of neighboring important structures, we use MEG and functional MRI with or without VADA test. Functional MRI again with or without VADA test for predicting memory decline. For language, functional MRI with MEG. Tractography for the white matter fibers. fMRI and tractography for cortical tracts identification and preservation. To summarize again, for neighboring structures, nowadays the VADA testing is not so commonly used. MEG has been shown to be very good test for cortical mapping, basically non-invasive cortical mapping. MEG has been shown to be almost on par with invasive cortical mapping when it comes to language and memory localization. So MEG and fMRI have literally almost replaced VADA testing for functional area assessment. So now coming to invasive techniques. First I'll talk about what are the invasive techniques and then I'll say why we have to use the invasive techniques. So invasive techniques, here basically we are using EEG for localization of the lesion. So when all the previous investigations have still not been able to show us any great value, then we come to something called invasive techniques. Here we implant electrodes into the brain, either stereotactically or by craniotomy or by certain other minimally invasive techniques. So the purpose of invasive techniques will be for an invasive EEG recording for better lesion localization and for brain function evaluation in terms of brain mapping and intraoperative electrocorticography. I'll talk about that subsequently. So when do we choose what kind of invasive techniques we have to use? So basically now coming to what are the different electrodes that we use, there's something called stereotactic electrodes and then subdural electrodes, stereotactically placed electrodes and epidural electrodes. These are the different electrodes that we have. Subdural electrodes will be grid electrodes or strip electrodes or FO electrodes. So first talking about subdural grid implantation method, it is done usually by craniotomy. So in the videos that Dr. Ravindranath was demonstrating, I don't know, I was not able to talk to him about the details of that, but most of the patients had bandages around their heads and there were EEG leads coming out of those bandages. So possibly they were implanted electrodes which were used for studying of the seizure semiology. So subdural electrodes are usually implanted by craniotomy predominantly, which are, we have two types, either strip electrodes or grid electrodes. Just a brief, so this is a strip electrode and these are grid electrodes. So we do a craniotomy and implant the electrode strips or the grid on the brain. So main advantage, it allows an optimal coverage of the subdural space adjacent cortex with adequate and continuous cortical surface functional mapping capabilities. So basically we have a greater area for evaluation and direct access to the brain. Limitations, when it comes to, now let me go slightly more into these details. Subdural strip electrodes are predominantly used for temporal lobes predominantly, because you don't, they are very superficial electrodes, and when we don't have much necessity for greater details, subdural electrodes might be sufficient. But when we need a greater evaluation or greater dimension, like the larger surface area has to be covered, particularly for non-temporal regions, that is frontal or parietal occipital regions, we may have to go for subdural grid electrode implantation. So the limitations are, usually when we are covering the brain with grid electrodes, the sulcal spaces are usually not accessed because we are only seeing the superficial part. And we do craniotomies only on the convexity side. We cannot do craniotomy, we cannot insert these subdural grid electrodes on the medial aspect of the brain. Whereas most of our refractory epilepsy seizures are arising from the medial part of the brain, that is mesial temporal lobe. So these become the limitations of subdural grid electrodes or strip electrodes. So the best candidates will be patients with clear cortical lesions. As I said, it's only on the superficial cortex that we have a better idea with these electrodes. Those patients in whom the main indications for the invasive evaluation is electrofunctional eloquent cortex mapping in the setting of a cortical lesion. So whereas when it comes to subcortical or deeper lesions, possibly subdural electrodes might not be of great importance, except something called FO electrodes. FO electrodes are something, they are called foramen ovale electrodes. They are inserted from here and near the foramen ovale, wherein there we have direct access to the electric signals coming from the medial temporal lobe. So subdural electrodes, in the subdural electrodes, FO electrodes possibly can have a better idea of the medial part of the brain. Otherwise, most of the subdural electrodes usually give idea of the superficial part of the brain. So to have an idea of the deeper aspects of the brain, we have something called stereo electroencephalography method, wherein electrodes, either rigid or flexible electrodes, are placed by stereotactic techniques directly into the brain. So the incisions are really smaller because we use stereotactic techniques there, and we can go to the medial aspects of the brain. So for example, mesial temporal part or cingulate gyrus or orbitofrontal cortex. These areas can be beautifully evaluated by stereoencephalography techniques. So advantages: allows extensive and precise deep brain recordings and stimulations. Disadvantages: a restricted capability for performing functional mapping. Contiguous mapping of eloquent brain areas cannot be obtained as there is limited number of contacts located in the superficial cortex. So, as I said, stereotactic electrodes are predominantly used for evaluating the deeper aspects of the brain. But if you use isolated deeper SEEG electrodes, we will not be able to map the superficial parts of the brain. So, what is the best way to do both? Combine both. So, this is called hybrid techniques, wherein we use both grid electrodes and this is stereotactic electrodes. So the best way is to have a hybrid technique wherein we use both grid electrodes and stereotactically placed electrodes to have a comprehensive picture of the surface analysis and also analysis of the deeper aspects of the brain. So now here this is just a small diagram to show where and what are the requirement indications. So now, if the patient is having, I'm sorry for the poor image quality, if the MRI is positive for a lesion, do we really have to use the electrode, deeper electrodes? If the lesion is in non-eloquent cortex, not needed. If the lesion is in eloquent cortex, we might need subdural grid electrodes with or without SEEG. Mostly subdural electrodes will be sufficient, because MRI is showing a lesion and we just have to map the eloquent cortex so that we don't damage the eloquent cortex. If the lesion is in the depth of sulcal lesions, I have already told subdural grid electrodes cannot identify the sulcal lesions. So we have to go for deeper electrodes, SEEG. When there is more than one lesion, again SEEG will be useful, and deeper lesions, SEEG will be useful. If the MRI is not showing any lesion, then SEEG is the best. And SEEG, basically more than SEEG, hybrid techniques will be the best way to evaluate. So now, I have talked about electrodes, deep electrodes, superficial electrodes. So how do they help? They help by helping, the use of these will be something called electrocorticography basically. These electrodes, implanted electrodes, help us in getting an electrocorticography. So this electrocorticography can be done either intraoperatively or extraoperatively. That is, we use these electrodes to map the brain and evaluate the ictal zone either during surgery or outside the surgery. That is, extraoperatively meaning during surgery many times what happens is we don't have much time. So we have only a very limited amount of time. During that time, patient might have seizure or might not have a seizure. We might not be able to identify the ictal zone or we might not be able to identify the ictal zone. So usually extraoperative electrocorticography is a preferred technique because we have more time for planning, we have a more time for detailed analysis of the brain and the lesion, and we have a better picture planned for the eloquent areas as well as the irritative zone. So these electrodes help us in mapping the brain. So because we can use either receptive or stimulative techniques to identify which parts of the brain have what function, whether language, memory, motor, sensory, all these functions are identified on the basis of the stimulation or receptive mapping, then we or stimulation or receptive electrical activity that we generate, and that is used to map the brain. So this mapping of the brain helps us in very precise localization of the lesion in relation to the eloquent areas and plan our surgical trajectory so that the surgical results will be better. So as I've said, one thing always, white matter fiber tracks are also very important when you're planning for surgery for epilepsy. So this is intraoperative recording. So now I told you I will tell what are the indications for invasive techniques. So when we have so many non-invasive techniques, do we really need invasive techniques? Yes. When the MRI does not show a cortical lesion in a location that is concordant with the electroclinical or functional hypothesis generated by video EEG, that is MRI negative cases. The video EEG or evaluation shows there is a lesion, but MRI does not show a lesion. We can have the necessity for invasive techniques. When the MRI shows a lesion, but or EEG or MEG, whatever, all the electrophysiological tests are not showing concordance with the existing MRI lesion, we might need invasive techniques. When there are two or more anatomical lesions with the location of at least one of them being discordant with the electroclinical hypothesis. So basically when we have more than one or two or more lesions, which lesion is responsible for the ictus and which is not, gets really difficult to identify, just purely on the basis of surface EEG or MRI. In these cases, invasive EEG might be useful. And to generate AEC hypothesis, the generated AEC hypothesis, when it involves potentially eloquent cortex, then to preserve the eloquent cortex, we might need invasive techniques to map the eloquent cortex properly and preserve the eloquent cortex. So finally, summarizing whatever I have spoken till now, the evaluation, pre-surgical evaluation of epilepsy patients is in two phases. Phase 1, non-invasive evaluation. Phase 2, invasive monitoring and evaluations. What is the purpose of these evaluations? To understand the focus and the epileptogenic zone, understanding and evaluation of the neighboring connected and eloquent structures and the consequences of the disturbances, so that finally we can give a fruitful surgery to the patient. So in summary, the purpose of all these investigations is this. I don't know how much has gotten into the brains, but anyhow, I end my topic with that summary. Yeah, so that's what. So recently we had some company coming up wherein we are using we are integrating the existing MRI with the functional MRI and tractography, and the sync is really beautiful. So yes, AI definitely is going to be a future technique which is going to be very helpful in more precise lesion evaluation and much refinement of surgical results.
Thank you, and Dr. Anand, I think because your time, we go to the final round, which you're all eagerly waiting for.
Thank you, Dr. Anand, for that detailed presentation. I now invite Dr. Preetham to introduce our next speaker.
So it's a great honor for me to introduce my teacher from NIMHANS to speak as an invited faculty in this seminar. So he's currently the professor of neurosurgery at NIMHANS Bangalore. He is a former additional professor at Sri Chitra Tirunal Institute, Trivandrum, and a former consultant neurosurgeon at Bahrain Defense Force, Royal Medical Services, Military Hospital, Kingdom of Bahrain. He also had worked as a consultant neurosurgeon and clinical tutor, Division of Neurosurgery, Department of Clinical Neurosciences, Riyadh Military Hospital, Saudi Arabia. So he has over 30 years of experience as an epilepsy surgeon and has performed over 1,000 epilepsy surgery procedures. So very few people in the world can boast of such numbers, and he is a very prominent figure in international epilepsy circles. He is presently the president of Indian Epilepsy Association and past president-elect of Indian Epilepsy Society, past president of Indian Society for Stereotactic and Functional Neurosurgery, past continental vice president for World Society of Stereotactic and Functional Neurosurgery, and he is a member of Stereotactic and Functional Neurosurgery Committee, WFNS. He is a member of Middle Eastern Society for Stereotactic and Functional Neurosurgery. He is a member of Epilepsy Surgery in Resourcepur Region's Task Force under Surgery Commission of ILAE. He has received multiple research grants, including the Science and Technology in Yoga and Meditation grant, DST and DBT Wellcome Trust grant, Science and Engineering Research Board grant, DRDO grant. He has over 90 publications and he has received multiple awards, including the Young Investigator Award awarded by the International League Against Epilepsy in 1999, Senior Research Scholar Award awarded by University of Melbourne, Australia in 2000, Commonwealth Fellowship Award awarded by Association of Commonwealth Universities, London, UK in 2001, and FRCS awarded by Royal College of Surgeons of England in 2013. Even though I wanted to be brief, I could not be very brief about this much accomplishments. With this, I welcome Dr. Malla Bhaskara.
So by staying till the very end, you have proven that you are really interested in this CME. I'll assure you, this is going to be short, sweet, in fact, like icing on the cake. Okay. Now, how many of you know the term action T4? Please raise your hands. You had this term any time? Okay, you can certainly do the Google search. These are people, real people with epilepsy. They were considered as a burden to the society. in terms of health, in terms of economy, in terms of resources. And when these people get married and have children, their children also will have epilepsy. So the burden is likely to increase. So during Hitler's term, the treatment for these people is action T4. Action T4 is to kill them. Anybody with uncontrolled epilepsy, treatment is to kill. This is the practice in Europe. But then these are all, of course, people who changed the course of history, course of mankind. And your HOD, that Anand Krishnan mentioned that there are many eminent personalities in the world who had epilepsy. So, in fact, last 200 years, the progress we made in the field of epilepsy, almost 90 to 95% of people with epilepsy can lead almost normal life. But in fact, if you see the actual reality, only 10, 15, 20% of people may be getting benefited. There are many barriers. There are many barriers in passing the benefits of this progress knowledge. And certainly meetings like this will help, and please join me in congratulating and thanking the leadership of the CME in giving us this opportunity to share our thoughts about these things. I'm sure you will agree with me that we had too much of epilepsy, isn't it? Since morning. So let me talk about few other things which will make you understand why people actually develop epilepsy and how we can take care of them. So I'll briefly touch upon these listed topics, and these two, hippocampal sclerosis and yeah, it's, I think pointer is not working on the screen here. So these two listed conditions are most common prevalent conditions. So I'll give you some examples about that. So I need volunteers. Anybody can tell what is this number? You are raising your hand? Okay, I'll read it for you. It is 37 trillion. 37 trillion. What is this number? You want to tell something? No problem. I mean, this is more interactive. I mean, I'm not going to stand there to teach something. This is just an interactive session. No, I'm sorry. We have 8 billion people on the planet. This is 37 trillion. Sir? I think he is more money minded. Sir, actually, if there's a number like that, we can talk about many things. But actually, they're the number of cells we have in our body. Human body, in each one of us, we have 37 trillion cells are there. So these cells are born, they grow, they perform their function. Whatever it is, wherever it is located, it will do its job. And if there is a damage because of injury, infection, tumors, they repair themselves. And eventually, these cells will give rise to daughter cells. It's a perpetual. So you lose a skin, you will get a new skin. If you lose a part of, if gut internal lining, mucosa is damaged, we will get new cells. So this is a perpetual life cycle of the cells. Unfortunately, This will not happen in the brain and spinal cord. So, whatever we are born with, it will stay with us. This is the famous neuron doctrine of Raymond Cahal. You know, for saying this neuron doctrine, whatever you are born with, just like how skin regenerates and all those things, the brain and spinal cord will not regenerate. For saying that, for proving that, Raymond Cahal got a Nobel Prize. You know, more than 100 years ago, he is a Nobel laureate. You see the last sentence, it is for the science of the future to change if possible this harsh decree. Scientific progress which happened during the past 100 years, in fact, suggested that regeneration or neurogenesis in fact happens. In 1960s, it was proven in the rat hippocampus. You know, rat lives, livelihood is to smell things, and then for eating and for mating and all sorts of activities. So, when there is very bad thing, this neurons in the olfactory nerves, they get damaged, so it has to be replaced. Regeneration, a lot of regeneration happens in the hippocampus. So, in 1960s, it was proven that neurogenesis happens actually, in fact. And then in 1980s, again this neurogenesis which happens is proven that it is activity dependent. For example, the songbirds, during their mating season, these birds sing to attract for mating, and when they sing, for singing, learning new tunes and all those things, new neurons are born in these birds. So, this was again proven that learning and neurogenesis are related. Finally, Peter Eriksson is a neurologist from Sweden. He took consent from people who are dying with laryngeal cancer, injected bromoxodiuridine, which is an ingredient of DNA. DNA has got that thymidine, uracil. So, this bromoxodiuridine gets into DNA. So, after they passed away, they volunteered to subject their brains for scientific research, and then when their hippocampi were studied, they had their DNA neurons with DNA, some of the neurons had this drug which was injected. BRDU was there in that neuron. So, that means those neurons were born after the drug was injected. So, it was not prior to that. So, it was proven emphatically that neurogenesis in fact does happen in humans. Again, this is the number of neurons we have in our brains. 86 billion neurons we have. So, this like if you have some money, 86 billion, you will use it where it is required. It's distributed according to the requirements and purpose. You know where are these neurons located mostly? Any guess? Where are these neurons, 86 billion neurons? Where are they located? Cortex. Sorry? Bit cells. Which is bit cell? No, which part of the brain these neurons are located predominantly? Madam? Okay, I'll give the answer. 69 billion are located in the cerebellum. We call from school onwards, we learn that cerebellum is small brain, small brain, small brain. So, actually cerebellum has got 69 billion neurons. nature will not do anything without a purpose. So most of our things, our behavior, our see for example driving, singing, a lot of things we do are all automated. Automation, cerebellum has got a big role in automation. Okay, so predominantly cells are in the cerebellum. Only 17 billion cells are there in the rest of the brain. Okay. Now, this is a marine creature, sea slug. You see, this there is a very famous experiment was conducted by Eric Kandel. Some of you must have heard about this name, Eric Kandel. So, when the gill was gently touched, the sea slug ignored it because of adaptation. Touching, light touch, sea slug ignored the light touch. But when there is pinprick, there is a withdrawal, sudden brisk withdrawal. With repeated pinprick, the sea slug withdrawal response time became shorter, very brisk withdrawal. So Eric Kandel studied that how it's happening, neurobiology, and then he found that with intense pain, actually the pain sensation is traveling up to the cell nucleus. Cell nucleus is making special proteins, and these special proteins are like memory molecules. They are remembering that with intense pain there will be pain, so gill has to be withdrawn. So that is in fact basis of learning. If it is suppose you read something very casually, very superficially, you may not remember. But with focus, with exam coming, and then with something you have to perform something, your full attention is on the task to learn. So your learning becomes much more intense. So this is the basis. This is the basis of all learning by plants, by primates, even human beings. And then Eric Kandel got a Nobel Prize for this experiment 24 years ago. So neurogenesis happens in the olfactory neurons. It happens in the periventricular area, and it happens of course in the hippocampus. So I'll confine to hippocampus for this presentation, but other things are also equally important. For example, even people with stroke and head injury and infections and all those things, they also recover. Some of them recover because of the periventricular neurons. Neurons are generated around the periventricular area, and in people with post-stroke, some of them recover because these periventricular neurons migrate to the areas where brain is getting infarcted. So now let us talk about hippocampus. Joseph Klingler. I think this is not working properly. Anyway, I'll leave it. So Joseph Klingler, he is a professor of anatomy. Joseph Klingler is a professor of anatomy, and he is the one actually who taught anatomy to Ghazi Asargil. And he made a comment that thank you. So he made a comment that hippocampus in all of nature is the most complex structure. So those of you are interested in to understand more about hippocampus, like Gray's Anatomy, there are big books are there on hippocampus. So this is even the next edition has come, 5th edition has come. If you are interested, you can go through this book. But in brief, this is the hippocampus. It's like a on either side of midbrain. So right and left two. It's about 4 to 5 centimeter structure. It has got head, it has got body, and it has got tail. Hippocampus has got about 1.5 billion neurons are there. Okay. Now you know that you are in Vydehi hospital. You are sitting in this seminar hall. Today is 10th of February. Today is Saturday, and all those things. All this information is embedded in the hippocampus. The time, space, all orientation is in the hippocampus. Actually, it has got place cells, it has got grid cells and all those things. So in a way, hippocampus acts like a GPS of the human brain. Again, for this work, John O'Keefe has got a Nobel Prize in 2014. See, all such a vital, important structures. And these two very famous personalities are there. Anybody knows them? No, excellent. Madam, what are you actually? Huh? Neurology resident. Okay, excellent. So he passed away recently. He's till recently he was known. Was this correct? He was known as HM. He is one of the most famous patients in neurology. And Brenda is a neuropsychologist who worked at Montreal along with Wilder Penfield. So Brenda Milner spent a lot of time studying HM. HM passed away recently. So he had uncontrolled epilepsy, and he had both hippocampi were removed. So after that, he lived almost for 40-45 years after surgery. His epilepsy got controlled, but he could never ever form new memories. He always lived in the past. After meeting him, he will nicely talking, and then after 5-10 minutes, he will forget. I mean, there is no record of any new this thing is there. So then people, I mean, because of patient HM, great deal of learning happened because of hippocampus, role of hippocampus in the field of memory. Until then, people used to think that memory is a lot more distributed in the brain. The focality of memory locating to the hippocampus we learned a great deal from the studying patient HM. So all these things happen in the hippocampus: the registration, the storage, and retrieval. The mechanism to convert short-term memory into long-term happens. Actually, hippocampus has got reverberating circuits. So what all happened since, for example, today's this CME, when you sleep, when you go to bed, it will be reverberating in your brain, and depending on the impact it had, suppose you have seen something dramatic, you have heard some word, something suddenly understood some concept, something like that. But during the reverberations, it will be encoded, and then hippocampus, and from conversion from short term to long term, and then again it goes to the cortical areas for long term storage. So that is the importance of hippocampus in the memory. So this is how it's initially all these things, all short term things will be in the frontal lobe, and then through the hippocampus will process the memory. Is it like its impact, its significance, and then eventually it goes to fornix mammillary body, to thalamus, and then again back to settles in the cortical areas. So if you take the human memory in terms of measurements, it is 2.5 million GB storage capacity is there for the human brain. That is the enormous amount of storage. Now, this reverberating circuits, the neurochemical neurotransmitters, the architecture also makes hippocampus vulnerable for epilepsy, for seizures. So many all these changes will happen at a microcellular level, which will make hippocampus because of either birth trauma or febrile seizures, forceps deliveries, or head injury, infections. All those things will make hippocampus vulnerable as a source of seizure. In fact, this is Asla. Asla is a basic science researcher at from Finland. So she has done a lot of work how a normal brain is converted to epileptic brain. You see, there is a long period of epileptogenesis running over a period of 10-15 years, where so many things happen: loss of neurons, proliferation of glial cells, and not changes not confined to neurons and glia, but even at the synaptic level. So many things happen, and then some people develop epilepsy, some people develop drug-resistant epilepsy, and this progression is dependent on multiple influencing factors. So if residents, if you are interested, you can read this paper about why people in fact develop epilepsy and then drug-resistant epilepsy. Now coming to the clinical practice, so in NASA has sent chimpanzees to the space, and to monitor the activities of the chimpanzees, their heart and their brain and their activities. This tele-monitoring system was developed, NASA has developed in collaboration with UCLA in Los Angeles. So Dr. Ravindranath has shown a lot of videos of patients, simultaneous recording of behavior and electrical activity of the brain. This is actually an offshoot of space research. From NASA has shared it. NASA has developed it in 50s and 60s, but then it became available for civilians in 80s. Same time, people started understanding the concept of drug-resistant epilepsy, and then imaging came into the advent. So you see here, this is the autopsy specimen, normal hippocampus, and this is a small and shrunken hippocampus. Whereas here you see this the normal, this the fragmented and with a lot of cellular loss. And those days the workup, with pneumoencephalogram, you introduce air and see the size of the temporal horn. Here it's a little bigger temporal horn. Same thing. Now of course it's very easy to diagnose these conditions on the imaging. Normal size and shape of the hippocampus. Here it is a small and shrunken sclerosed hippocampus. So this became available for civilian use in the 80s and 90s, and also randomized controlled trials proven that resective surgery, resection of this sclerosed hippocampus has got significant improvement in the You see, compared to 8% with continued medical management, here almost 60% of people had seizure control. So this had worldwide implications, and then I had an opportunity to perform the first hippocampal resection in India way back in 95 in Sri Chitra Tinnal Institute, along with my neurologist colleague Dr. Radhakrishnan. After that, of course, I have done personally over 1,000 surgeries, and in India more than 12,000 epilepsy surgeries were done with outcome at par with industrialized countries. For those who are new to epilepsy surgery, I'll just give you a few illustrative cases. This is a young girl, engineering student, who had uncontrolled epilepsy. This is a snapshot. If you look at her, this hand has got a dystonic posturing. It's a stiff dystonic posturing. It's a snapshot of an evolving seizure over a period of few minutes. So there's a head turn to the left and then the dystonic posturing. This dystonic posturing is a very robust sign of seizure which started on the left hemisphere and close to mesial temporal area, and from mesial temporal area the seizure has propagated to the basal ganglia. When seizure has gone to basal ganglia, the hand has gone into the dystonic posturing. That's how neurologists will localize the seizures. And then if you see her MRI, there is a left side hippocampal sclerosis. You see, this is the size and shape of the normal hippocampus. Here it is small because neurons are dead. So because of neuronal loss, it became small. And then there is a hyperintensity is there, white signal is there, that is because of the gliosis. And if you look at the interictal as well as ictal EEG, this color coded, it's for surgeons to understand. EEG, this even numbers are right side, odd numbers are left side, and it's also color coded. So this is a system called 1020 system. You see here, this the you know that T temporal 1, 3, 5. They're all odd numbers on the left side. There's a ictal onset on the left temporal area. Both interictal spike phase reversal as well as ictal spiking is on the left temporal, and MRI is showing the left hippocampal sclerosis. So these are like ideal candidates for surgery. And this is a very brief video. Can I show? Time is there, or Pritam was telling that since I am a surgeon and this is a surgical talk, so we should talk about surgery. So anyway, this is a very brief video clipping. So this is hippocampus. This is the left hippocampal resection. This is the left frontal lobe. This is amygdala. Its amygdala is a nucleus surrounded by temporal stem white matter. So amygdala is being resected en bloc. Floor of the temporal horn hippocampus. Amygdala is in the roof. This is the choroidal fissure. Anterior choroidal artery enters the temporal horn to supply choroid plexus through the temporal horn. This is the femur fornix. The head of the goes. So it's about 4 to 5 centimeter structure. In people with mesial temporal sclerosis, there's a shrinkage of hippocampus because of loss of neurons and gliosis. So it becomes the normal 4 to 5 centimeter structure will become less, maybe 3.5, 3, even 2.5. This the head of the hippocampus is being lifted, and just below you will find the brainstem, the cerebral peduncle. So this is the it is being cut at the head body junction, and below this is the hippocampus proper. This is the fimbria. And just below that, this is the dentate gyrus. This part is dentate gyrus, and it's opened like a book. And this is the hippocampal sulcus. The blood vessels to hippocampus come from the posterior cerebral artery and occasionally from even few maybe from the anterocoroidal. So they are being coagulated. This is a very important step. Otherwise, while removing the hippocampus, there can be traction spasm of the posterior cerebral artery leading to significant deficit, even sometimes death also. So now this part is being lifted. This is the entorhinal cortex. Entorhinal cortex is the most epileptogenic tissue in the entire human brain. This entire block from here to here, it's like an en-block resection, about 3.5 centimeter of the hippocampus proper and parahippocampal gyrus, all being resected en bloc. Of course, you can use CUSA and then fragment the tissue, but there won't be any diagnosis. So the documentation of mesial temporal sclerosis is an important predictive factor. Subsequently, to reduce the anti-seizure medication and then follow up the patient. So it's like an en bloc resection of the hippocampus. Uncal herniation is a rule in these people with hippocampal sclerosis, suggesting that either during birth or febrile seizures, meningitis, encephalitis, they herniated and then survived. So this is the proof that of the old herniation, uncal herniation. So uncus is being lifted, and uncus and remaining part of amygdala is being resected. So this is what you see at the cavity. This is the posterior cerebral artery, cerebral peduncle, and the anterior choroidal artery. This is the cavity. So two things are of prognostic significance. One is the post-op MRI showing complete resection of the mesial temporal structures, and the second one is the resected specimen showing features suggestive of hippocampal sclerosis. These two are very important predictive factors, and they guide in the overall management, including the drug reduction over a period of time. And this is the patient. See, we like head injuries and oncological surgery. The epilepsy surgery is highly rewarding in the sense that a person, child who could not go to school, young people who could not study, could not get jobs, could not get married, could not have children, all of them, once surgery is done, they become normal, productive members of the family. So this is the engineer, of course, with their permission, I am showing the picture, leading a normal life. This is another young boy who is a budding musician. Actually, while competing in a music program, he had a seizure, and the judges gave him time, an hour, to recover from seizure, come back and then perform. So this is he had an uncontrolled epilepsy. You see, compared to the left hippocampus, the right hippocampus is small. You can see indirectly there is a enlarged temporal horn. Even the slight change in the size of the mammillary body also. So he had a right temporal epilepsy with EEG and MRI concordance. Since he is a budding musician, my colleagues at NIMANS, they have done a lot of work, including fMRI, music fMRI, and then he underwent awake craniotomy. And while listening to music and identifying the various components of music, we resected his hippocampus, and this is the extensive reorganization of resting state fMRI prior to surgery. This one is prior to surgery. This is 1 week after surgery, and this is 1 year after surgery. So there is a lot of reorganization happens in the brain, And this, of course, this the progression of I mean the development suggests cognitive and neurogenic reserve potential in the human brain. You know, children who are very good in sports, very good in studies, very good in fine arts and all those things, when in case unfortunately if they suffer any head injury or infection in later life, their recoveries will be much better because they have a lot of reserve cells, reserve potential. So this boy, this is I think after a year after surgery, I don't know, I think I don't think. So now this boy is on the way to Berkeley University in US to learn about Western music. So this is the a life changing sort of treatment. This young lady went to UK for epilepsy evaluation because the clinical evaluation could not lateralize the seizure onset. So invasive evaluation was suggested in UK, but the neurosurgeon there referred the patient to India and NEMANS. So at NEMANS we have evaluated. With non-invasive evaluation, we could able to lateralize two things. One is this PET MRI, which showed decreased metabolism on the right side, and then MEG showed a cluster on the right side. MEG is right is right. So MEG showed right side cluster. With that, we could able to avoid invasive evaluation and then took her for surgery. Again, you see here, this is a young man who had a typical temporal lobe epilepsy. Only thing is that the MRI showed loss of volume on the left side, whereas EEG is showed ictal onset on the right side. So again, this is because there is volume loss on the left side. This is a false lateralization to the opposite side. So he also underwent based on the MEG. He also underwent surgery on the damaged side without avoiding implantation, because if I'm just giving roughly, if surgery costs some 50,000, if you put electrodes it will cost 5 lakhs. Many of our patients cannot afford this sort of implantation. Occasionally it is required. So compared to the temporal lobe surgery, extratemporal lobe surgery is more difficult. I'll give you just few examples and then I'll stop. So for example, this is a DNET which is involving the motor cortex and it's involving there. This is the one which you have been hearing since morning, focal cortical dysplasia. You see there's a transmantle sign all the way up to the ventricles. I'll just give you some idea about this condition and then I'll stop. So this 86 billion neurons we have, they're all generated around the ventricles and then they move, and the neurons which are generated around the lateral ventricles and move to the cortical mantle are all excitatory. Neurons which are generated around the ganglionic eminences around the third ventricle, they're predominantly inhibitory. Okay, so this is I think so this is how a neuron which is generated around the periventricular area will move to the cortical mantle over a period of 72 hours in this study. So, because of genetic predisposition, in utero insults, perinatal events, this sort of orderly neurogenesis and then migration to the cortical mantle and then organization in the cortex will not happen in some cases. So, that leads to a group of disorders known as malformations of cortical development, and cortical dysplasia is the most prominent example of that. You see here, this is the cortex. Cortex is about 4 to 5 millimeter, and this is the white matter. Whereas here you see the it is thick. It is more than 4 to 5 millimeters, and then it is blurred. Here you can see sharp demarcation, but whereas here it is a thick, it is blurred, and it has got bizarre looking large dysmorphic neurons. These neurons are intrinsically epileptogenic. So, and they can be anywhere. Hippocampal sclerosis is mesotemporal, whereas these malformations can involve any part of the brain. Very challenging. NIMHANS, we operated about 150 cases like this over the last 12 years. Some work is published, and I'll just give you 2 examples, and then I'll stop my presentation. So this is a young girl who had left focal seizures, very frequent seizures, 15 to 25 seizures per day, going into epileptic encephalopathy. See, this is their behavioral this one with the easy correlate. You see, it's a predominantly left focal seizures. You look at both hands. There is a almost it's like a jerking. This hand is jerking, and hand and leg are jerking. So it's like a 20-25 seizures leading to epileptic encephalopathy, and extensive anatomical abnormality. You see, this is the omega sign central sulcus, and this is the motor cortex corresponding to premotor area to post central sulcus. There is a anatomical abnormality. Child is going into epileptic encephalopathy. So, in a way to save life, we have to resort to extensive surgery. You see, the PET showed that there is a decreased metabolism in the entire anatomical abnormality. MEG showed a dipole cluster which is inferior and posterior to the anatomical abnormality, and so she underwent large craniotomy. This vein is roughly in the central sulcus area. So the intraoperative ultrasound, you can see the normal sulcal gyral pattern here, whereas this whole thing is abnormal here. So based on all the, and also of course corticography showed active persistent spiking in that anatomical abnormality, and then she underwent she, of course we have explained to the family that there is going to be significant deficit, but in order to save the life she underwent resection of the entire dysplastic cortex, which is involving the eloquent area, motor cortex. This is the initial part of the this is the midline, and then you can see the pericallosal arteries there. It is very firm area with no gray white demarcation. This is that vein which you have seen on the surface. This is the part of the lesion which is you see, it is like almost like a tough sclerotic part. So the entire thing was removed post resection is normal. This is the resection cavity, and this is the post resection ultrasound, and this is the histopathology suggestive of type 2 cortical dysplasia, and this is the child has got deficit but able to walk with proximal control. There is a distal loss of power, and this is another child. This is a 4-year-old girl. This child presented with more like a drop attacks, atonic seizures, and she had an extensive malformation in the anatomical Broca's area. You see, this is the left side of the brain. This is Cillian fissure, and it is involving the anatomical Broca's area. Again, this child is going into epileptic encephalopathy, and we could not do any of these studies which are being done in adults. For example, fMRI could not be done, even invasive evaluation also was not possible. So explaining that likelihood of having a deficit, we went ahead, and then this the PET showed decreased metabolism in that area, and MEC showed dipole cluster in that anatomical abnormality. This is the ultrasound done during surgery pre-resection, and this is the left Cillian fissure. It's a left Cillian fissure, left temporal lobe. This is the left inferior frontal area. So this is the abnormality which has been delineated, and you see this surgery. It's a dysplasia, but it's almost like a tumor surgery. It's very firm area, and with no gray white demarcation. See, this is the Cillian fissure. You see, it is being resected. This is the resection cavity, and this is the post resection showing that extent of resection. This is that area which has been removed, and then type 2 dysplasia, and then remarkable plasticity in children. She's talking, and then she's got no focal deficit. This is a follow-up at 2 years after surgery. So the common features between these two surgeries which I showed, both had dysplasia, both had eloquent, one motor and one language. Both we could not do invasive evaluation. Both we could not do awake craniotomies, and both underwent gross total resection. So at NIMHANS, over the last 12 years, about close to 600 people underwent surgery, including 137 of various types of malformations, and we found that there are some of the preoperative, predictive factors. For example, anybody who has got seizures for less than 5 years, and less seizure score, less number of drugs, and clear-cut discrete lesion had a much better outcome, and then those with other factors like more than 5 years duration and high seizure burden and more than 3 drugs, they had 3 to 4 times less favorable outcome compared to the good outcome. And of course, the outcome for FCD is more FCD and glioneuronal tumors like net and ganglion is more persistent compared to other types of malformations where there is a significant drop there. So all these procedures have got risks are there, but the risks of surgical interventions are not higher than the risks of adverse effects of the anti-seizure medication. Anti-seizure medication itself has got significant risk. So these surgical risks are at par with the risks of the medication. Of course, technology is helping us, and all these resected specimens, they're like a gold mine to do research in epilepsy and then drug-resistant epilepsy, and then at NIMHANS lot of work is being done. So I'm sure you will be starting your surgery here soon. So you also get involved in research. If there are no facilities, please preserve this tissue. It's like gold mine. You can keep it even for 100 years. And if you want to send it to NIMHANS for preservation, that also can be arranged. You can collaborate with other centers. So I hope there are young people are there in the audience. I hope my presentation served a bit more like a motivational talk. So with your interest, involvement and commitment, I'm sure hundreds and thousands of lives of people with epilepsy can get better. And apart from Ravindranath, these are all my colleagues at NIMHANS, and thank you very much for your attention. And this is my email. Yes, sir. Thank you, sir, for a very interesting, informative, and intellectual session also. It's very outstanding work, and you made the lives of many, many people much, much better. I'm sure many people will be inspired. I wish I had a long period to get inspired by the senior also. Very interesting. This is open for questions. Sir, you were talking third slide was the birds will sing and yeah. So, I am a neonatologist. We are doing many things. We have started playing, occultation or modulations, like I am into, because we are playing in our LIC that circuit which are the more occulation, like I think other thing for my small 800 gram of baby and other things. And sometimes somebody told birds, somebody told some noise, which is better. So your question about that information presented on the slides. So the no neurogenesis happens, and neurogenesis happens is not a statement made by one person. This is a knowledge evolved over a period of 100 years. No neurogenesis happens is Raymond Cahal's famous neuron doctrine, which got him Nobel Prize. 1909 Nobel Prize was given to Raymond Cahal for neuron doctrine. Neuron is the end product. Like blood, new blood will form. Neurons, no neurons will form. That is his idea. Now these songbirds, they were actually, these birds were sacrificed, and their brains were studied, and then all these new neurons were found, because this neurogenesis is activity dependent, learning when they're singing this one. So this is like if you learn, suppose tomorrow you learn music, or you learn martial arts, or you learn some new activity, neurogenesis happens for you, for me, for everybody. This is how current evidence is suggesting. Now, can you please repeat once again your second point? The avian study, the songbirds, the brains were sacrificed and then number of neurons were counted physically. That's how new neurons were detected in them, and then that too particularly during the mating season. Yeah. What is the second point? Can you please repeat? Neurogenesis is not happening. That was the concept 100 years back. Now it's all proven. Science has proven that neurogenesis happens. Yes. Is there anything like modulation changes and neurogenesis, synaptogenesis will increase? We know that So there are two concepts. One is cognitive reserve hypothesis. Second one is neurogenic reserve hypothesis. So the I'll tell the applied aspects. Poverty, drug addiction, loneliness, alcohol, this drug intoxication, all these things will lead to loss of neurons. Whereas exercise, diet means two things: intermittent fasting and caloric restriction, and music, meditation, sleep. All these things will enhance neurogenesis. So at one end you have factors which will cause loss of neurons. At other end you have factors which will enhance neurogenesis. So it depends on where the person falls. If person is like a child who plays, who studies, who listens to music and performs and involved in multiple activities, will have enhanced neurogenesis. Whereas if there is a young person, for multiple factors, suppose if he is lonely, addicted to substance abuse and all those things, will have loss of neurons. So this is proven. Now you are talking about cycles. So if somebody has to have neurogenesis, neurogenesis is activity dependent. Suppose if we are involved, if we encourage children, we force our children to study, but at the same time we encourage our children to learn to music, listen to music, play sports and also study. Multimodality stimulation will have enrichment. A lot of neurogenesis happens. It is proven. I mean, now neurogenesis can be measured. You can do MR spectroscopy. You can do cognitive assessment. Neuropsychology will tell whether neurogenesis is happening or not. Clinical assessment, including some spatial orientation test and all this. In cognitive assessment, they can tell whether somebody's neurons are going down or going up. And functional imaging studies, a lot of things will tell whether neurogenesis is happening or not. And did I address your points, Madam, Sarita Madam? Anything from your side? Yes, sir.
I have one comment, just emphasizing the last few points I made. Whatever child is referred, it should be referred before 5 years. Even if you do a lesion close to an eloquent site, they can shift the ability to the other side and be left with no significant disability. So that is very well brought out by various studies. And as regards neurogenesis, I want to say that our intelligence is a product of both innate ability and the environmental enrichment. It is said to be about 60 to 30%. So 30% is environmental enrichment which contributes to one's intelligence. That's how environmental deprivation deprives the people of their innate ability to shine and exhibit their talents in society.
Yeah, actually our learning is not dependent just on the schools and teachers and all those things. Almost last 200,000 years, from one generation to the other generation to the other generation, lot of coded information is passed on from generation to generation. Many things, suppose all of us are behaving well, not just because of our school. We are conditioned to behave like this for hundreds and thousands of years. Yes, sir.
I see much thank you very much for coming. My apologies for the thin crowd, but you've got a hardcore crowd here.
Yeah.
I'm sure you really benefit from your excellent talk. Thank you very much.
Thank you. Thank you.
Thank you so much, sir. You are an inspiration to all of us young doctors. We hope that we can continue with the same passion and energy as you. Thank you so much.
Thank you. Thank you.
I now invite Dr. P.C. Mohan, HOD and Professor of Department of Neurology, to please felicitate our speakers. Thank you, sir. I request Anand sir to please accept a small token of our appreciation. I now invite Dr. Rashmi from Department of Neurology to deliver the vote of thanks.
caterers, the photographers, Icon Life Sciences for their support in this
Thank you, ma'am. Thank you to all of our esteemed guests, speakers, all of the attendees for your patient attention. We will now break for lunch. Please do enjoy your food. Huh? We will now have the national anthem now. Please be stand. Jana mana adhinayak jaya he Bharat bhagya vidata Punjab Sindhu Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga Uchchala Jaladi Taranga Tava Shubha Name Jage Tava Shubha Ashish Mage Gaye Tava Jaya Gata Janagana Mangaladayaka Jaya He Bharat Bhagya Vidata Jaya He Jaya He Jaya He Jaya 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 He. Thank you. We will now break for lunch.